55-year-old gentleman, resident of Nalasopara, presented with chief complaint of hematuria for the past 5 to 6 days.
Whether the hematuria is painful or painless, it is total, associated with the clots or not.
Can you hear him?
Yes, sir. The hematuria was painless, it was gross, total, and it was associated with blood clots, not associated with any tissue bits.
Is the patient has any loin pain?
No. No loin pain was there.
History of lithuria?
No lithuria history is there.
You know, here at this point, I think it is necessary to know the severity of the hematuria before you go, because whether this was severe enough for admission, whether it is happening every day. So that's an important aspect beyond painless and painful.
Still patient is having hematuria, it's stopped.
It was not self-limiting. The patient had to be admitted in the hospital for that.
Okay. What is the shape of the clots?
It was cuboid in shape.
The patient is taking any history of anticoagulants?
No history of any anticoagulant or antiplatelet use is there.
The patient has any history of bleeding disorders?
No bleeding disorder is there.
Any recent instrumentation?
No recent episode. This was the first time he had presented with hematuria, and this episode is for 1 week.
Any instrumentation?
No past history of instrumentation is there. This is the negative history. He had no history of pyuria, lithuria. There is no history of fever with chills, no LUTS, dysuria or abdominal pain, no suprapubic or flank fullness or lump, no history of any anticoagulant medication, no bleeding disorder, no history of anorexia, weight loss or bone pain, no history of facial puffiness, dyspnea, lower limb edema, or any history of trauma or surgical intervention in recent past.
Is the patient is a smoker? I want to know about personal history. Is the patient is a smoker or any form of tobacco consumption, chewing?
Patient has history of tobacco chewing for the past 5 years. He is having mixed diet, appetite is normal, and sleep and bowel habits are normal. No comorbidities are having. He is having.
You can see.
What is your sort of working hypothesis now?
CA bladder.
CA bladder.
Patient is a known case of tobacco chewer, and
why can't it be a little bit more general rather than specific?
Bladder tumors.
Why not use a even more general word?
You think that it is only a bladder or something else?
Can it be kidney?
Sir.
Can it be ureter?
Yes, sir.
Can it be prostate?
Yes, sir.
So why don't you just say the history of painless hematuria with clots is highly suggestive of malignancy in the urinary tract.
Sir.
Let somebody ask you what malignancy you think it is.
Sir.
Then you proceed. If you just say CF bladder, then two things are possible. If you are right, the examiner will say you've been tipped. If you are wrong, then the examiner will tell you, see, you don't think of anything beyond cancer. Both ways you are screwed. So,
patient is not having any loin pain and low history of urinary tract symptoms.
alright. Is it necessary? Is it necessary to have all this for malignancy? Huh? It is not necessary. When you have malignancy in the urinary tract, it is not necessary to have any of these symptoms. That is why painless hematuria with clots, the prime world over, everybody will hunt high and low for some cancer somewhere in the urinary tract. Alright.
The only sir is trying to tell you can't be as specific as clear bladder.
That's why. That's why.
Yeah.
Yes. I want to know the general examination of the patient.
General condition is fair. ECOG one status is there. Pulse 20 minutes per minute. BP 110/80. Afebrile. There is pallor was there. There is no icterus lymphadenopathy or edema. On per abdominal examination, the abdomen is flat. There is umbilicus is centrally placed and inverted. There is no visible lump or dilated veins. There is no localized tenderness or warmth, though no lump palpable. There is no organomegaly. On per rectal examination, anal tone is normal. Prostate of grade 1 is there, and it is firm, smooth. The mucosa is free, and there is no nodule present. Rest of the systemic examination is normal.
Okay, Dhanush, tell me, what are those urinary tract malignancies where the findings are negative? Which pathological conditions will be there where the findings are not there? There is no findings, but it's a malignancy.
Urothelial cancer.
Urothelial cancer, where urothelial starts from one end to the other.
UT from upper tracts and lower tracts also.
Upper tract and lower tract. Right. Anything else? Any other malignancy where there are no findings? Only like this. No? You have not seen? Bladder cancer?
Sure.
Patient comes like no findings, only ultrasound shows one tumor. That's it, nothing else. No findings. Huh? How about kidney?
It has a triad of cross hematuria, long
Triad is there, you're lucky, but without a triad, can you make a diagnosis? See, I am asking you the question in a different way. The same question I asked you before, but I am asking you the question differently. Yeah? In the light of the fact that there are no findings here, we still have to consider all these possibilities.
Now, the question which is asked, and we need to answer in two ways. One, if the patient has symptom and you don't have a normal clinical examination. Patient does not have hematuria, but normal clinical examination, but having a urological malignancy. There are two possibilities. So you have to answer that question. You have to dissect that question. When you have to answer. Okay.
Carcinoma in situ, the patient will have intense storage symptoms.
We are talking of hematuria. We are not talking of pain at the moment. We are just talking of hematuria, painless, that's all, some clots are there. Okay, so now what will you do now?
I will investigate the patient with the first blood investigations and we'll go for
what are the important blood investigations that you will do?
For this patient, hemoglobins. The patient is having painless cross hematuria since 1 week and associated with the clots. Hemoglobin with PCV. And
supposing the hemoglobin is 5 grams, what is your inference? Report comes hemoglobin is 5 grams. What thoughts go through your mind?
We'll check it. Is clinically the patient is having pallor or not?
No, it's 5 grams, man. 3 times they have checked it. How many times you want to go and check? 3 times they have checked it, 5 grams. What is the inference you will draw? You want to know? You want to know what? You look at this issue. I want you guys to learn, man. I want you guys to think about every situation.
Blood loss is
How long is this hematuria now?
since 1 week.
1 week. Hemoglobin is 5 grams. Huh? In 1 week, if you have dropped your hemoglobin to 5 grams, what does it mean?
Either patient is having lot of blood, very
It's a
heavy.
lot of blood. Does it look like? Is that the story?
No, sir.
No. That's not the story.
The patient he himself is anemic.
What does it imply?
Is a maybe malignancy.
Okay, we are talking of malignancy. What does it imply? I want to know. Although the history of hematuria is only about 5 days, drama has been going on inside this fellow for a long time. He's been having something which is slowly eating away his system. You drop his hemoglobin without knowing, and suddenly presents as hematuria 5 days later. I mean, just 5 days before he comes to you. If that is the situation, then the story would have been he comes with clot colic or clot retention, they have to wash him out, they admit in emergency. The story is not there. He came into the OPD. That's what Madam asked. The severity of the illness, how long, what is the severity is also to be assessed. So if you had assessed the severity in the history, the hemoglobin of 5 grams, the answer would have come out later. You get it? So, then what's the other investigation you do?
Serum creatinine.
Right. What other investigation apart from hemoglobin and creatinine? Hemoglobin दिखाओ भाई.
Hello, 8.7 grams.
8.7. Not very far away.
And creatinine of 0.7 is there.
Right. So now what do you do?
Ultrasound abdomen release.
You will do ultrasound or you will do CT scan straight away?
We'll go for office ultrasound, sir. We want to confirm whether the patient is having hematuria since 5 days.
Exam. We have used the word office ultrasound. Examiner will ask you, why you don't want to do CT scan? Office CT scan. You may say office CT scan. You have said office ultrasound, it's office CT scan. How will you answer that question? How will you counter it?
Office ultrasound we can do that one in bedside, sir. We can just come.
No, that's not how you will answer. Because you are a Vedanayagam hospital student. He will say, sir, we are trained to do ultrasound, we have got an ultrasound here, so the patient comes, we quickly do the ultrasound. That's the answer he will give. Because you use the word office ultrasound. Nobody knows. You have to present yourself also, no? Your image, body language, image, what you say, give confidence that, oh yeah, I could scan and see, I know how to do ultrasound. Example, you know how to do ultrasound? Yes, sir, I know how to do ultrasound. We are doing regularly. Oh, I see. Okay. Then the question will be dropped there. Alas, you go to another track. So you must learn also the art and all this answering at all these interviews and exam is an interview only. What is? So don't feel shy or diffident. I am asking you to do CT scan.
Yes, sir. If on ultrasound, if it is inconclusive or suspected large tumors, then we go for a CT scan.
No. Here is a situation where a patient has got clots, short history. Hemoglobin is 8 grams. He has been unwell obviously for a while. Just 5 days you drop the hemoglobin level without any emergency, no clot, nothing. When you suspect the diagnosis of malignancy to be very high priority, in today's world with normal creatinine, it is better to go for cross-sectional imaging. Why? Why will you do cross-sectional imaging? We asked you, no? I asked you one question, no? What are those malignancies where there are no findings?
So any
Yeah, that is why you do cross-sectional imaging. Before cross-sectional imaging came, we would do IVU, cystoscopy, retrograde. That's all we had. Then ultrasound was thrown in, and now all these fancy images have been thrown in. So naturally, you want to go for the best, yeah. Huh? So the investigation of choice. If the examiner asks you what is the investigation of choice in this patient, you would say CT scans with contrast. You understand how the questions will be asked and how the play which goes on. Huh? Another group will say, what did you sir? I will do ultrasound. Okay, what different? That is one line of examination. Probably the fifth candidate for the day is tired, he is bored, so he is asking a straight question. You are very lucky. But if you are the first candidate, the fellow is fresh, he'll ask you all like this is what I tried to ask. Should not get phased out. Okay? Go ahead. Show ultrasound. Yeah, I saw one ultrasound come.
Ultrasound on the right side, the size of the kidney is 9 cross 4.5 centimeter. Normal echoes and maintained CMD. The system is undilated. On the left, 9.9 cross 5.1 centimeter. Normal echo, maintained CMD, and mild HN with HU is there. Anteroposterior diameter of pelvis is 1.2 centimeter. The bladder is distended with urinary catheter seen in situ. Approximately 100 cc of heterogeneous content seen within bladder without any vascularity.
Why the patient was catheterized?
He was brought to our casualty with complaints of hematuria and retention. So, and he had hematuria, so we placed catheter and started irrigation for him.
How much of clot was evacuated at that time?
We had posted him, and in the on cystoscopy we had evacuated around 75 to 80 cc clot.
Any other question you'll ask you? Any other question you'll ask? He gave you some information now.
What is the cystoscopy findings?
Very good.
On cystoscopy, he had a growth. Around a large growth was present at the left lateral wall extending from the bladder neck up to the left posterolateral wall with left ureteric orifice could not be visualized separately. We had taken representative biopsy for him.
Right. Now, supposing cystoscopy showed this clot, they washed the clot, there was nothing, there was no tumor in the blood. What will the next line? The next part. To understand the question, cystoscopy was done, bladder wash was given, clot was evacuated, nothing inside the bladder, no tumor. What will you do now?
We'll go for urine cytology.
You got the cystoscope.
Upper tract, we'll go for we'll
Cystoscope.
We'll collect urine from the orifice.
Hello? You will collect urine or you will do something else?
RGP.
You will do RGP, but there is no CM. There is no X-ray for it. You didn't suspect all. You put him in the OPD and that put on scope and washed him out. But you can still do something else. With the scope inside there. You have not seen what Dr. Vishwarup does. 20 minutes he will be spending ogling the bladder, even when it is normal. He has an affinity towards that structure. When he does cystoscopy, he'll go into ecstasy also sometimes. You haven't seen, You have not seen SVK do scoping.
Vascularity.
Vascular. 2 holes are there coming out. Yes. 2 people I've seen very patiently observing the orifice. Honestly, I'm telling you. One is SVK, the other is very patiently. I'm telling you honestly, I don't have the patience. Everybody waits. If it comes, it comes. But when the high index of suspicion, It's very important. It's very important at that point to examine the orifice and watch it and see the reflux, because it's a sure sign, man. If there's blood coming from that right orifice, you know. And when it comes, it's a very definite finding. Comes. Have you seen blood coming from the orifice? It's like a tap which opens. It's there. It's a fantastic finding on cystoscopy, and I think you must all learn to observe the scopy. Very important. Especially when you have a patient with hematuria and the bladder is negative. And you got the scope inside. It just so happened that they had the scope inside because the fellow was in clot retention. So use that opportunity to gain some more advantage. You understand? So you have to think, I'm doing a scopy, what are the things that are going to go, what am I going to get out of this scopy if it's normal? What's my plan? What's my strategy? Alright? You understand?
Sure.
Okay, proceed. Now they've shown you this. Now what will you do?
What was the HP report? We'll go for it.
No, presently the biopsy was taken.
Biopsy was taken. That's
We'll go for CT scans. Contrast with contrast.
Yeah.
The mass is very long.
You will do plain CT or you will not do it?
The creatinine is normal, so we'll go for contrast CT scan.
No. Will you also do a plain CT scan along with it?
First,
What is the importance of doing a non-contrast CT in a patient whom you suspect to have a malignancy, whether it's renal or bladder? What is important? At least as far as renal malignancy is concerned, or renal tumefactions or growths are concerned, why is it important to do non-contrast CT? And a thorough non-contrast CT, not just some ordinary 2 cuts here and there. No, very important. Why?
look for the calcifications.
Look for something weird. See, we are talking of, I'm giving you renal masses. We are talking of somebody with hematuria. It's not bladder tumor. I mean, I'm not talking of this particular case. I'm just asking a general question, which can happen in the exam. The examiner knows that he's got, this fellow got bladder cancer, but he wants to ask another question. He has full right to ask you. So he will ask you, what's the importance? Because you said CT scan, he suddenly ask you this question. In a patient whom you suspect to have something in the kidney, why is it important to do? Remember, you're still dealing with hematuria. Okay? AML. Alright? Whenever we have somebody with hematuria, we think everything is cancer. It's not necessary. There are benign conditions also. And this is a classical benign condition where the non-contrast CT is absolutely on the basis of that only you decide that contain this. So that you look at the radiopedia, radiology books, this is the reason for doing a non-contrast CT. Okay, show the CT scan.
This is the plain film.
Slow.
Okay, right. For the last 2 days, constantly dead.
Next. Next.
That we had in the this.
Arterial phase.
Yeah.
What is it?
Next.
Yeah. Correct. Just hot water.
Next.
Yeah.
Next.
Now the patient dressing.
Venous phase.
நல்லா இருக்கு எல்லாம் கைக்கு விட்டேன் நீ அப்ளை பண்ணி ஆயிட்டு வீட்டுக்கு போகணும் ஒரு டேட் சொல்லணும்
The delayed phase.
Sure. This is a contrast enhancer CT film which is showing the abdomen and pelvis with the kidneys appears to be normal with bilateral uh, hydronephrosis is there with the mild. There is
You don't want to
no
tell us
mass
anything
lesion.
about the kidneys. Such a
They don't
major
accept.
investigation costing 6,000 rupees. Patient wants something, no? You go to a hotel to a nice restaurant, you get something. What is this then? He is disappointed. Same thing here. That's all reported. 8,000 rupees for these 2 lines you are going to give him. Give something more beneficial. Yeah. Is there any calcification? You should know some calcification. Is there any stone?
No calcific, no lesions, no
Start
mass
with a
lesions.
proper order. There is a CT scan of the abdomen and pelvis from point A to point B. You know where you're taking is including there to there. Extent. The plain CT scan shows. Hey, report, man. Not just report it. The plain CT scan shows no evidence of calcification or radiopaque shadow in the kidney or the bladder. Adrenal glands are normal, not normal. All that. From the urology point of view. Then you go to the other organs. They could be mesenteric calcification. Don't mention in the exam unless you see it. But you know, these are things that calcification can be anywhere. It's a plain CT scan. But
The bladder wall.
see, the problem here is you know the finding already. You know the ultrasound finding and the cystoscopy finding you know. So now you have blanked your mind off to looking at the CT scan. And your mind is focusing only on the bladder. It is not focusing on the other thing. What you have said is mild hydronephrosis, then you went straight to the bladder. That's when I stopped. I don't want you to do that. You guys are starting to present, so get into the habit. So that when the time comes for the exam, you will be on top there. You will know, you will have no problem. So this is how it is. You understand, no?
Yes. This is a contrast enhanced CT film showing the abdomen and the pelvis.
No, it's alright. Don't. I'm just telling you. Remember this. Next time when you see it, this is how it is. If you repeat the same mistake again next time, then I will know that you haven't benefited at all from the class. We still take the class for you, but we did not progress beyond whatever. Okay, carry on.
The bladder counter appears to be normal and the capacity looks adequate. And there is a mass lesion seen in the bladder, large mass lesion seen in the bladder. Previous slide.
Tell him.
Previous slide. Back. Arterial phase.
Is there only mass lesion or something else in the bladder? Apart from the mass, is there something else in the bladder?
Foley's bulb in situ.
Apart from Foley's, there are blood clots, no?
This is with contrast or without contrast?
With contrast.
With contrast.
Huh?
With
This
contrast.
This is with contrast.
Yes, sir. Yes, sir.
Then will you show me the delayed cleanse? Stop.
Look at this film carefully. Look at this film carefully. Yes, this one and the next one also, both are about the same, but look at it a little carefully. So, show this. What? Look at it a little bit more carefully. It's supposed to be delayed phase, no?
Yes, sir. Contrast is not filling the bladder completely.
It will be urine, no, at least the whole bladder should look white, no?
Sure.
Only parts of the bladder looking white.
Maybe large blood clot.
That's what madam is saying, no? That's what madam is saying.
Next.
You see?
There is a large blood clot is there at the hole is bulb in situ.
There is some
Large-
contrast, there is some clot, the bladder is not filled. Anything else you see?
There is no perivesical fat standing. Sir.
No, describe the bladder wall. Dr. Mohan and NU classes, same thing, no, describe the bladder wall, what's happened to it? There is a big lesion inside the bladder, what can it do to the bladder? What can this lesion do to the bladder?
Any travaculations?
Can it infiltrate the bladder?
Sure, yes.
Tumor, man, can it infiltrate the bladder wall?
Yes, sir.
If it infiltrates the bladder wall, what will happen to the bladder wall at that point?
Contour will change.
Contour will change. So will the symmetry be lost at that point? See,
Yes.
talk about all this. See, it's a
Sir.
large lesion, isn't it? Immediately when you have a large lesion inside the bladder, so much of clot, you begin to wonder whether this is muscle invasive, isn't it?
Sir.
So immediately your mind is thinking of muscle invasive. What all can I do? You can do this to the bladder, you can do this everywhere. Describe all that. I know this is probably the first case you're presenting, eh?
Sir.
First case. Yeah, it's all right. It happens like that. What you're seeing every day in the world, same thing is being presented. There is nothing new. You see the bladder is symmetrical, distending uniformly. Is there anything between the wall, pelvic side wall and the bladder? Huh? What about the ureters? So the next one, delete. See that? Can you see the ureter in this?
Sure.
And the other side you can still see some more. Next cut. You see now these two cuts you see?
Sure.
So it's very important. The lower ends of both these ureters appear to be dilated.
Sure.
Is there any evidence of stranding? Perivesical?
No, sir.
It is not there, it's not there.
It is on.
The bladder is uniformly distended across. But at the same time, these two ureters are dilated. Isn't it?
Sure.
Can that happen?
Yes, sir. If growth is large and if it is covering the orifice, then dilated ureters may be dilated.
Okay, covering. Does it have to be muscle invasive?
Sir. Yes, muscle
No, it
invasive.
doesn't have to be. It doesn't have to be muscle invasive. You can have a large superficial tumor covering both the orifices to produce adenovirus. See, if you look at say muscle invasive bladder cancer, both the lower ends of ureters are involved. There must be some other evidence before the ureters are involved for this bladder tumor. There's nothing else. The wall of the bladder is there, good. There's no perivesical stranding. There's nothing there. So, are we dealing with a bladder tumor which is Non-muscle invasive covering the whole thing, or are we dealing with something else? What else can give rise to this appearance? Where there is hematuria and both the ureters are dilated and the bladder wall appears to be good.
UTUs,
Huh?
upper tract cancer.
Upper tract cancer, both ureters, lower ends, man. Lower ends. What other organ is there? What other organ is there?
Prostate.
Prostate, yeah. Prostate. Okay. So it could be prostate. As I told you, don't think of the cystoscopy findings. Your mind is getting biased by the cystoscopy findings that were told you already. Think from basic. Okay.
We'll go for
So what is your first diagnosis? What's your first diagnosis?
bladder tumors, carcinoma bladder.
You think it's muscle invasive or non-muscle invasive?
So there is a chances of muscle invasion is more, sir, because the tumor appears very large. It is
Okay.
great. So we'll send TUR biopsy.
They have taken some biopsy. You want to know some details?
Yes, I want to know the histopathology report of those biopsy.
You want to know any more details?
Is there whether the tumor has been completely resected or not?
So you want to know how was this biopsy taken? How was this biopsy taken? Was it a pinch biopsy? Was it a resection biopsy? Did it include the muscle base? It's a large tumor. Did you attempt to do a complete clearance, or did you decide that you wanted to just do a representative biopsy with bladder and base and leave it because you strongly felt it was a muscle invasive bladder cancer? Those are questions you have to ask. Right. So, what was done, man?
Sir, we had just taken a representative biopsy.
Right.
And the biopsy report is this one, sir. High grade urothelial carcinoma, lamina propria invasion was seen, muscularis could not be identified.
So, what did you do now? This is the biopsy report which has come. What is your next step?
Muscularis is not involved. So we can go for RETU or BT.
Not can.
So we'll go for RETU or BT.
I will take the patient back in again and do a formal TURBT, either with completion, but certainly to include the base where I can get muscle. What else will I do when I take the patient back to theatre?
We'll start resection from the edges.
No, what else will you do before you start the resection?
What you could not do the last time you had to do, no?
Oh, you got under anesthesia, no?
Yes, sir.
Then
Bimanual.
bimanual examination. Don't
bimanual
forget, man. All you guys keep forgetting that simple clinical exam. Patient under anesthetic, he's got his legs up, put a finger in the rectum, do a bimanual, confirm that this is either this is mass there or no mass there. The most important thing is, whenever you have a patient under anesthesia, even if you're not in the case, before your boss or anybody starts, just put a glove and do a rectal exam. Get into the feel, the habit of feeling how things are normally. Alright? Whether it be a man or a woman. Under anesthesia is the golden chance for you to understand what physical examination is. Of course, in today's world, it makes no difference. Nobody does any physical exam. We are all very old school fellows, so what to do? We will only put finger in the rectum, we will do this, we will do that. Anyway, so, very important. So now find out what is it.
What was done?
Actually, we went ahead with radical cystectomy and ileal conduit.
So what was the
Could
final?
anything else have been done? Could anything else have been done before radical cystectomy? Okay, let me ask you one question. Why do you think they opted to go for radical cystectomy at the outset itself?
Cystoscopy findings, and they feel like
Okay, okay.
the tumor is very large. There is a probability of more muscle invasion is there.
Okay. Anything else? Any other reason why they went ahead with cystectomy?
On safety finding, on biopsy finding.
High grade urothelial cancer.
Yeah, high grade. Is radical cystectomy a treatment for high grade PCC?
Yes, sir.
Yes.
Sir.
Radical cystectomy is still in many centers a treatment for non-muscle invasive bladder cancer, high grade, large tumor, because the risk is high. What is the other risk? What is the other risk in such a patient? Large tumor, high grade. AEM, can you answer that? What's the other risk? What is the other risk of leaving such a patient alone? Instead of doing cystectomy, they are doing cystectomy. But if you opt not to, what is the percentage of lymph node disease in a patient with high grade PCC? Is there a risk of occult lymph node metastases in a patient with high grade PCC? Answer is yes. That's why I'm asking the question. Okay. So there are patients who will have lymph node metastases in high grade PCC. Alright. So large tumor size. Patient came with severe bleeding, dropped his hemoglobin, must have been an emergency sort of situation. You can't go on pumping him blood from one side. You've got a tumor there which is high grade. Go ahead and take it out. Save his life. So now what's the next question you'll ask him?
What is the final HP report?
Very good. What is the final biopsy report? Anything else you will not ask? Anything else you'll ask?
Intraoperative findings, no? You want to know, you can ask something. You may know whether nodes were enlarged or whether it was stuck anywhere, whether the ureter was involved, because they will be cutting the ureter, right?
No, both sides ureters were dilated there.
Intraoperative findings and final HP report.
Intraoperatively, ureters were not involved. It was free. We were able to dissect on all sides, and we performed radical cystectomy. There was
On-table frozen section was.
no frozen section was done.
It is a large tumor and
Why do you want to frozen section? You do well. Frozen section of what?
ureter cuttings.
It was free and nothing there. I was free. Now that you have raised the question, next class for 5 minutes before they present the case, tell us about the role of frozen section of the ureter in a radical system. Okay? 5 minutes. That's all. The role of frozen section, because you raised that issue. Okay? So that's your job. Any other biopsy report you want to know?
The prostate prostate in
Prostate, you want to know? Anything else you want to know?
type of cancer.
Already they said high grade
High grade.
disease. What else?
Lymph nodes.
Lymph nodes, man, very important. Huh? You want to know lymph nodes and what are the extent of the lymphadenectomy? Was it a standard PLND? Was it extended? Do you think they would have done standard or extended in this patient?
Maybe standards.
Yes, why?
CT shows no lymph nodes.
Correct. Yes. So the CT had shown something different, then you would go for it. Okay. So you understand?
Sure.
Right. What is the final biopsy? Oh, got it.
Hello.